thousands are raving about our best-selling 100-patient scenario book, and so we started creating the expansion books to go along with it, including the cardiac arrest scenarios, we have the airway scenarios, pediatric scenarios, and the MCI scenarios. And you can get this entire bundle at the link in our bio. This is Mastermedics. Mastermedics is an online learning tool made specifically for EMT and paramedic students. We've had 10,000 students come through us to transfer this textbook knowledge into their minds. And it works because it's fun, it's visual, and it's engaging. And if you want to try it out for yourself, you can start a 3-day free trial right now at the link below.
All right. Welcome to another live class on for another case study breakdown, the final one, for 2024. And then we will get started again in 2025 for the next 12 days. We're going to be doing some throwback stuff. So some of the best videos that we did throughout 2024, you'll be seeing them throughout the next 12 days to kind of keep you guys just watching some of these 1-minute videos to enjoy. So that is what we have in store for you for the next 12 days. But today we are going to do our final case, and that is going to be a septic patient case to talk about kind of the best practices that we know of right now for our septic patients. I just need a little bit of water here. For those of you who haven't seen me before, my name is Geoff. I'm the owner, lead educator of Mastermedics. I'm one of the people that you see on here doing videos and doing these live classes. A bunch of the other instructors that do these as well. But what we're going to be doing is we're going to be breaking down a case that I showed you earlier today. And it is a septic patient. And we're going to talk about kind of the pathophysiology and the treatment for that. And so if you haven't seen Mastermedics before, you're going to see a very different approach to education, very visual approach that we like to use that really works well for our students. And so we're looking forward to showing you what we can do here and how we can manage these patients. And so while we're waiting for everyone to populate in here, why don't we go ahead and say where we're watching from in the comments. So where are you watching from? Where in the world are you? Just says you've never skip a Mastermedics live. Well, I appreciate that. Do you recommend any study apps or programs for national? Yeah, like we have one. And so for those of you who don't know with Mastermedics, we do have a national prep for our students. And so we have thousands and thousands of students that have gone through our programs. And so it's not just exam prep, it is the education behind it as well. So anything you can find in a textbook, we have a course for it that you can go through and understand things quite a bit better than trying to read through your textbook, because we use a very different approach than what you're going to see with anyone else. That being said, is that we do have a 94% pass rate for anyone that does our National Registry exam prep, our Canadian exam preps, any of those exam preps, we have a 94% pass rate. So we do have some excellent results with that. We even send you a coin if you are successful to say congratulations. We back our our success with congratulating you and with guarantees as well. And so we're a proven resource for National Registry. And so if you're interested, there's a free trial, so you can check it out for yourself. You even get a free book with it as well to read and to workbook to kind of go through some of the exam questions in there. So I think you should check that out first. I might be a little biased on that, but I think it'll be a big benefit to you. All right, let's see what we got here. From where are you guys all from? Where can you buy it? If you go to the link in our bio, you will see the link there. That's probably the fastest way to check it out. New York, Tanzania, very cool. Russia, UK, Toronto, Australian paramedic working in California, right on. South California, Arizona, Long Island, Utah, Germany, South Africa, Virginia, Tacoma, Idaho, Miami. Wow. All over the place. That is fantastic. Georgia. Right on. Okay. So I think we've got enough people in here. North Dakota, South Africa. Fantastic. So let's talk about this case and this patient here. So let's skip right into it and take a look. We already kind of did our little plug. You are dispatched to a male patient complaining of fatigue and shortness of breath. You find the patient on the couch, pale and with a productive cough. He says he's been feeling unwell for 4 days and today felt too sick to move. Too sick to move. That's kind of what we're dealing with here. This is your patient. He is on oxygen. Okay. And he has been quite sick. You can see he's quite pale, pretty fatigued. So we have a pretty good idea of what our patient looks like. And then we hook him up to the monitor. And this is what we get. This is what we find. So judging by what you see here, what is seen as safe, BSI, you have your BSI on. Okay, judging by what you see with these vital signs, what is some things that are concerning to you? What are some things that are concerning to you? What do you think? Heart rate, blood pressure, SpO2, high shock index. So yeah, it's about a 1 and a bit. 1.2. Low SpO2. Stop 100% on O2 on the guy. I agree. Heart rate, SpO2. Okay, I agree with you. I think that we have a lot going on here. We have a few things that we need to deal with. So first off, let's circle the thing. So heart rate, absolutely an issue. Blood pressure, absolutely an issue. And then we have a breathing rate at 20, SpO2 at 88%, and end-tidal CO2 at 35. So luckily the 35 is good news. It means that he has some sort of perfusion still going on here. That's good news. We'll take that. The SpO2 is not great, 88%. And then we have a blood pressure 106. So let's talk about this blood pressure for a second here. So this blood pressure says 106 on 86. So he's not hypotensive from, textbook standards. Let's agree on that. He's not hypotensive on textbook standards, but look at his heart rate. If his heart rate is that high and he's only able to produce that much blood pressure, that's a problem. Just because you don't see the under 90 particularly doesn't mean that this person isn't sick. A heart rate of 123 should absolutely be able to produce more than 106 systolic blood pressure. So this patient 100% is very sick. And they're barely compensating. They're barely holding on. So this guy is not doing well. And what's the problem? Well, there's a lot of things going on here. Being unwell for 4 days, productive cough, being pale and requiring oxygen, okay, we're probably dealing with some sort of infection in the lungs. That is probably explaining the SpO2. Now, My first question that I asked you in the case was, is this patient septic, or do they fall under the criteria of sepsis? What do you think? Does this patient fall under the criteria of sepsis? Yes, no, maybe so. What do you think? Go ahead and put your thoughts in the comments. Do you think this patient is septic? 103 degrees Fahrenheit for a temperature as well. Temperature is 103 degrees, which is 39 and some change Celsius. Yeah. 103 degrees. Blood sugars, okay, that could be one way or the other. Do you need 2 to 3? You're absolutely correct. You only need 2 of the 3, okay? And so, is this patient have a temp? Yes, he has a temp. Even if he didn't have the temp, and he's still saying that he has a productive cough, he's been feeling unwell for the last 4 days, he has an elevated heart rate, he has an elevated blood pressure, and he's a decreased SpO2. Now, these two, the respiratory rate and the heart rate, is enough elevation to suggest that this patient does fall under SIRS criteria. Okay, this patient falls under systemic inflammatory response syndrome. And so that is an indication that this patient is in fact septic. Okay, this patient is in fact has a systemic infection. That is absolutely a problem. Okay, so this patient is 100% septic. Okay, there's a lot of evidence to suggest that. Even without blood work, even without cultures, those things will confirm our suspicions. But as far as EMS goes, there's enough evidence here to suggest that he is septic. Now, why is that a problem? Why is it important to identify this? Well, when it comes to the body itself, when it comes to perfusing the body, we are basically perfusing our body based off this equation. Heart rate plus the stroke volume, or sorry, times the stroke volume, not plus. Okay, let me get rid of that. Okay, times the stroke volume equals cardiac output, and then cardiac output plus the systemic vascular resistance equals the blood pressure. And so if, for example, we have a decrease in our heart rate or a decrease in our stroke volume, that will cause a decrease in our cardiac output. And all of that combined will cause a decrease in our blood pressure. On the contrary of that, just for another example, if you have a decrease in your systemic vascular resistance, which is the fluid pressure in the blood vessels, then you'll have a decrease in your blood pressure. And so when we have decreases in our blood pressure, we have hypoperfusion, which is shock. So that's how our body maintains itself when it comes to our blood pressure. If our blood pressure goes down because of systemic vascular resistance problems, then we're going to increase our heart rate and increase our stroke volume in order to compensate for that. If we have a decrease in our stroke volume and our decrease in our heart rate, then we're going to have an increase in our systemic vascular resistance to try and compensate for the decreases in blood pressure. That's how shock works and how our body tries to compensate for it. Now, what's the problem in systemic shock? Okay, what's the problem in shock? Do we have a heart rate problem? Do we have a stroke volume problem? Or do we have a systemic vascular resistance problem? What do you think? Which three? HR, SV, or SVR? Lung sounds are crackles on one side. So do we have a heart rate problem, a stroke volume problem, or a systemic vascular resistance problem? Luke thinks it's vascular resistance. Sergio thinks it's vascular resistance. KI Devil thinks SVR. And I 100% agree with you. Okay, so how does this all work? Well, when it comes to an infection itself, if I get a cut on my arm and I get bacteria or anything like that inside that cut, what's going to happen in that little area is that I'm going to have more permeable capillaries, meaning that I'm going to dilate my capillaries in order to get fluid from here and immune cells from here to fight that infection. Okay, if I have a little cut here on my arm and that occurs, that's fine. That's not going to have a big impact on the rest of the body. But if I have a systemic infection, if I have an infection all over the body, we're now turning that one permeable capillary or small area of capillary that's going to be, dilating to the entire body. And so all the capillaries are now leaking fluid because we have a systemic problem or a full body problem. And so we end up with a decrease in systemic vascular resistance. And so this is your problem, because all this fluid that's supposed to be in here to create pressure is now leaving because of an immune response. So creating a big problem here. So this is what we would call distributive shock, okay, where the fluid is distributing from where it's supposed to be to where it's not supposed to be. It's distributing out. So that's an example of distributive shock. Another example of distributive shock would be anaphylaxis. Very similar pathological process to how sepsis works. We just have the cause of it being a little bit different. Okay, so that's a distributive shock. So our problem is here. And so the elevated heart rate that we see is actually compensation, because this problem right here is causing a decrease in our blood pressure. And so our heart rate and our stroke volume is going to increase in order to try and keep this guy from going hypotensive, and so that way the body can maintain itself. That's what's going on. Okay, so now that we know what's going on, let's talk about how we can manage it. Okay. Now, there's a few ways that we can manage this patient. So Eric's asking, please explain why this patient still looks like they have adequate tissue perfusion, evidence of ETCO2, yet blood pressure is low. I want to have some understanding of ETCO2 on septic patients. Okay, so let's go back and answer this question, because it's a very good question. Okay, so you're asking about, explain why this patient has adequate perfusion but still has a BP that is low. Okay, so it's because of the problem that's occurring here, is that we have adequate tissue perfusion because of compensation. So we have a decrease in systemic vascular resistance. This is your problem. Okay, and that is going to cause a decrease in your blood pressure. That is also a problem. Now, the reason that you're able to maintain is because in order to compensate for this problem, our heart rate and our stroke volume increases, and these are compensating. That is why in the beginning, or when we saw the vital signs, our vital signs were still 106. Okay, this was our blood pressure. Okay, so we were able to maintain adequate perfusion because of our compensation. Now, ETCO2, where does that come into play? Well, ETCO2 and its relationship to perfusion is actually due to the lungs. So if we have ETCO2, okay, remember all of this blood is circulating, okay? I'm trying to draw an arrow, it's not working, okay? It's all circulating through these alveoli. When you have inadequate perfusion, you have inadequate CO2 making it to these alveoli, which means that the ETCO2 would read, for the most part, quite low. And it's due to an inadequate of perfusion making it through the alveoli. But because of our compensation factors, at this moment, we are able to have adequate perfusion. That's one reason that end-tidal CO2 is unimpacted, because we have adequate perfusion. The other reason is that we have a heart rate, or a respiratory rate, of 20. Okay, and so it's slightly elevated, which means that we're going to breathe off a little bit more CO2 than we normally would, which makes sense because in a septic patient, we create acids. Okay, we have a higher metabolic rate, which creates more CO2, which creates more acid. And so having an elevated respiratory rate is actually to compensate for that, to breathe off some CO2. And as sepsis gets worse, this respiratory rate is going to go higher and higher and higher, and thus impacting your ETCO2. So you actually have two impacting factors on ETCO2 when it comes to sepsis. You have perfusion, flow of blood through the alveoli, and then you have respiratory rate or minute volume that's blowing off that CO2. 2 reasons. So hopefully that makes a little bit of sense. Usually I need a good 15-20 minutes to explain that. So hopefully that was enough to kind of like grab your attention and understand it a little bit differently. Okay, so that is why you have adequate perfusion right now. So let's talk about treatment for this patient. Well, treatment's quite interesting with this patient because treatment is all about what we want to replace what we've lost. Remember, our issue with this patient is that they have lost what? They have lost fluid inside their vascular space. And so one of the first treatments that we should be looking at doing is trying to replace some of that fluid. So one of the first treatments that we should be doing with these patients, with the exception of putting on oxygen for this patient because they were hypoxic, is that this patient should start on a 20 mils by kilo bolus. Now, this doesn't mean to just completely flush them with fluid. This is just saying that we should try and get fluids on board and start a relatively high amount of fluids. This isn't just throwing on a liter bag, opening it up and saying, go. Okay? 30 mils per kilo. Let's say this patient is 60 mil or 60 kilos. Okay? If they're 60 kilos, then they're getting a significant amount of fluid over time. But you want to be able to calculate those fluids. So that's what these sepsis guidelines recommends right now is 30 mils per kilo. It's actually come down. It used to be much higher than that. So that's the first thing, is that we want to give a significant amount of fluids, calculated fluids, in the first 3 hours of treatment. So when we identify septic shock, that's why it's so important that we identify SIRS criteria. We're not waiting for blood cultures. We're not waiting for blood to come back to say that we have a high white count or anything like that. We are simply using the vital signs that we have to identify it so that way we can start fluids earlier. Because if we don't start fluids earlier, the mortality rate of these patients, straight up. Okay, so that's the first thing. Now, the next question I want to ask you, what's better? Normal saline or lactated ringers? Go ahead, put that in the comments. What's different? What's better for these patients? What do you think? What's better for these patients? What would you rather? If you had the choice between the two, which one would you use? Paul's thinking lactated ringers. Bo's thinking lactated ringers. Well, I would tend to agree with you. I think that this patient benefits more from lactated ringers for a few reasons. Is that there was a test between normal saline and lactated ringers, and with patients that had balanced isotonic fluids, which is lactated ringers, it's a balanced isotonic fluid, is that they had a higher they had a less chance of renal or poor renal outcomes. Okay, and lower mortality compared to saline. So balanced fluids like lactated ringers outperformed normal saline in several different categories. So if you have the choice between the two, lactated ringers should be what you're using in these patients, in any shock patient for that matter. Okay, especially when you're using high volumes of fluid. Because normal saline, because of its high chloride amount, it can actually cause more acidosis in these patients, okay, and actually further worsen them. So ideally, using a balanced fluid is going to help you in a few different cases. One, it's going to decrease the chances of acute kidney injuries. It's going to decrease mortality, and it's going to lessen the chance of hypercaloremic acidosis, which is essentially a form of acidosis because of chloride and the high concentration of it in normal saline. Okay, so that's my answer to that question, is if you had the choice, which one would you use? Now, sometimes fluid's not going to be enough. Remember, these vessels are very dilated, so it might require a lot of fluid in order to actually get these patients to in a state in which they can actually respond to that fluid. You're going to hopefully see that heart rate decrease. You're going to hopefully see that blood pressure increase a little bit and normalize. But in a lot of cases, we're going to have refractory hypotension. Okay, and so when we have refractory hypotension, the best option that we have is to go with a vasopressor. And so the first line vasopressor that we typically use will be norepinephrine. And when we compare it to other vasopressors, this is our best first line vasopressor. Now, why is that? Well, for a few reasons. One is that norepinephrine is outperformed, well, dopamine for off, everything outperformed dopamine, but norepinephrine outperformed dopamine in a SOAP trial in 2010. And then when there was a comparison between epinephrine and norepinephrine, there was a similar impact on blood pressure, but there were more side effects with epinephrine, particularly more production of lactic acids. And lactic acids in septic patients, well, they may be transient, but they can have an impact on the efficacy of your medications, meaning it's not going to perform as good because the more acidotic you are, the more your medications actually don't work. So norepinephrine just had just as much of a response to the blood pressure, but had less side effects, which is another reason why norepinephrine kind of takes the reins there. And finally, there was no significant difference between mortality in epinephrine and norepinephrine, but there were some side effects between epinephrine and norepinephrine. Okay, and again, norepinephrine had less of those side effects. Okay, so when it came to all of those, when it came to a lot of this, or kind of to sum it up, norepinephrine performs just as well as epinephrine. There's no difference in mortality. However, there is more side effects with epinephrine over norepinephrine. So if you had the choice between the two, the safer choice and the better choice from the side effect perspective is norepinephrine. Okay. And finally, our last thing that we should look at and has a major impact on sepsis is antibiotics. So delaying antibiotics in sepsis is strongly associated with increased mortality. So again, another reason why sepsis is so important to identify in EMS is because the earlier sepsis is identified and treatment starts, the better chance this patient has to live. The longer treatment goes without being done, the higher the mortality rate is. And that goes for antibiotics as well. So what we're looking at here is a patient that has a higher mortality rate for every hour that's delayed in giving antibiotics. So when we identify sepsis, we should be relaying that to the hospitals so that way they can start their protocol on giving early antibiotics to decrease the mortality of sepsis. Okay. That being said, if you do have antibiotics on your ambulance, this is the patient that this should be used for. Is that when you identify sepsis, the earlier antibiotics are used, the better chance this patient has. Now, I know a lot of EMS does not have it, but if you do, this is the patient that you use it on. Now, there's a question is, why would you use fluids before you use norepinephrine? Well, it all comes down to the physiology of what's going on with this patient. I'm just going to back up to give you a visual. So why are we using fluids before norepinephrine or any type of vasopressors? Well, the main reason for it is because of where the fluid is distributing to. Remember, the fluid has already left the vascular space. Okay, and so if we just use, say, norepinephrine and squeeze these vessels up, okay, it doesn't really matter if we squeeze these vessels up if the fluid's already gone. Okay, the fluid's already distributed. And so the idea is that we want to refill this space with fluid before we try and squeeze it. Because vascular resistance is all based on the pressure of fluid in these vessels. If there is no fluid in the vessel, then we can't generate pressure no matter how much we squeeze. That's why we want to use fluids prior to norepinephrine. But the earlier we use norepinephrine, the better this patient is. And so if you start to introduce fluids and then you add norepinephrine on top of that patient, that would be the most ideal combination. But you still want to get some fluid in these vessels prior to using norepinephrine. Great question. Any other questions? We're kind of at the end of the talk here. And just to sum up on this, what did we do as far as treatment goes? Well, first we had to identify sepsis. Okay, and we used SIRS criteria with the vital signs to identify that. The next thing that we wanted to do once we identified it is to start fluids, which we did. So we started fluids on these patients to get their vascular resistance back up, to get fluids back into the vascular space. The next thing that we did was that if we still had refractory hypotension after fluid infusion, that we started on a vasopressor. And then from there, if we had the ability to do it, we would give antibiotics. So that's what I have for you today for our septic patients. Pretty straightforward for the most part. Any talk on vasopressin? That's a great question. So vasopressin is another medication that can cause vasoconstriction, and vasopressin is often a second-line medication for sepsis. So what happens in sepsis, when you have a decrease in pH, okay, when your pH goes down, your drugs have a reduced efficacy, meaning that if you had a normal pH of your body, and you gave norepinephrine, then you would probably see a 20, 30, 40 point increase in your blood pressure. Okay, but if you have a significantly lowered pH, your adrenergic receptors that norepinephrine impacts don't respond very well. So you gave the same amount of norepinephrine in a patient that now has a decreased pH, you might get a 10 or a 15 point increase in your blood pressure because those adrenergic receptors are not able to respond. And so why is vasopressin second line? Is that if your norepinephrine fails to increase the blood pressure because efficacy is reduced, then vasopressin doesn't impact the adrenergic receptors like norepinephrine does. Vasopressin is a hormone that is allowed for a neurotransmitter that's allowed, or sorry, it's a hormone that's allowed to impact the blood vessels and bypassing those adrenergic receptors. So it doesn't need those dormant adrenergic receptors, and it has an impact even if pH is decreased. So that's why vasopressin can be a great second-line medication if norepinephrine is not having the effect that you want it to go on. Great question, Trevor. In a 60-kilogram patient, after how many liters would you say it's safe to start adrenaline? So how would I manage this patient? So if I had a 60-kilogram patient, 60 kilograms times my 30 mils. And so 6 times 3 is 18 plus add 2 zeros. So if I'm doing this wrong, make sure that you correct me. I don't do great math in my head. But am I right about that fluid number over the next 3 hours? I think so. Okay. Make sure I'm right about that fluid before I continue with this, because I don't do math in my head very well. Okay, I think I'm right. So anyways, to answer your question, when would I start norepinephrine? In this particular case, I have 1800. I'm going to cut it in half, okay? I'm starting at a blood pressure of 106 and a heart rate of 130, okay? So my blood pressure is 106 and my heart rate is at 130, okay? If I put in 900 mils of fluid, and I do not impact these numbers, then I'm starting my norepinephrine and continuing to infuse the rest of my fluid. So basically, I'm going to give almost a liter of fluid, reassess, and see if I've had any positive impact. If I haven't had any positive impact at this halfway point, then I'm going to start my norepinephrine. If I have had an impact, a positive impact in my blood pressure and my heart rate, then I may maintain or continue to give the rest of my fluids without norepinephrine. So it really depends on how this patient responds. I don't want to give norepinephrine just for the sake of giving norepinephrine. I want to see if my patient can manage and to see if I can have a positive impact with the least amount of introduction. If I have that with 900 mils of fluid and I have a positive impact, then I'm going to maintain and continue my fluid infusion without norepinephrine. If I don't have a positive impact, this is the halfway point that I'm probably going to be starting norepinephrine on and continuing fluid infusion. Great question. Any other questions? Yeah, vasopressin is the hormone that gets like antidiuretic hormone. Is the one that controls vasopressin naturally in your body. And so vasopressin can be a very potent vasoconstrictor as well as water retention medication. So basically your glomerulus is going to basically constrict completely so that way you don't lose any fluid and you maintain it inside your body. So it's a great medication in combination with norepinephrine. On its own, I don't know what the evidence says about being a first line, but yeah, great second line. I've seen it work a lot, and we transport a lot of septic patients in my line of work with flight, and vasopressin is a very common medication for us to use. I don't see any other comments. Okay. Well, I think I'll leave you there. Like I said, if you are a student and in EMT or paramedic school and you're struggling in school, we would love to see you as a Master Medics Premium member. You have a lot of students that are watching this video right now that can attest to what we do as an organization to help students and help schools. We have a lot of contracts with schools as well. That being said, we've added a lot over the years. We have AI tutoring, we have one-on-one tutoring, we have patient scenarios. That scenario that you saw, we shot that scenario. We have dozens of those scenarios. We have free textbooks. Everything inside the membership on top of all the content that we have. And so you're getting a ton, all-inclusive content inside the membership that's going to help you through school and help you through your exams. We would love to see you. There's a 3-day trial to check it all out. So that way you can make sure that it's something that's going to work for you. And if it is, you can stay as long as you like. If it's not, you can cancel at any time. And you can still enjoy all the free stuff that we give out as well. So that's what we've got for you. If you do have any questions, you can go ahead and throw them in the comments. This live will still be up for a little while. And I'll try and answer your questions. But I will see you in the new year. I'm taking a little bit of a break. And we're going to, you can still message us and talk to us. We still have a team that's still going to be working through the Christmas break. But I need some downtime with the family here. So I'm going to be going on a little bit of a break, but we will still be around. We'll still be posting lots of live videos, and we will see you in the new year with a whole fresh new look at how we're going to be doing these cases and these premiere videos. So thanks again for joining me for all of 2024 and on and beyond. We've been around for about 8 years, and some of you have been literally coming to these classes for those entire 8 years, and I truly value you and coming to these classes. Has been pretty incredible to watch. So thanks again for joining me, and we'll talk to you next year. Bye for now.